Right, thank you so much for staying with the Monday Report. This is the conversation that we had mentioned earlier on, to reopen or not. A lot of feedback is coming through. Let me introduce my guest to you real fast. Dr. Lukoye Atwoli is the Vice President, Kenya Medical Association, is with us. And also Dr. Githinji Gitai, the CEO, Amref Health Africa. Thank you so much for making time for us, gentlemen. So, should we even be talking about reopening the economy now that we are reporting double digits, Dr. Githinji?
Yeah, Trevor, you see, I think I've said this before, that it's not about on or off. It's not a switch that you switch on or off. It's actually a dial that you adjust as you go, but based on certain scientific evidence, based on several things. Number one is that in what phase do you think your infections are at? Right now we are seeing growth in terms of numbers, but the question is, are the numbers increasing every day so that the new cases are more than the previous day? There are things to look at in terms of what we call the virus reproduction rate. You know, how many people is one person able to infect? If each person is able to infect many people, then you have to reduce that rate down to about one person to one or below one. So there are many things to consider, but remember that it's not all about the virus. It's also about the economy. It's also about people's lives. So this is what I'm saying. It's a dial to adjust rather than a mechanical on-off. And therefore, every government has to think about its journey. There's no playbook for this thing. Every government is coming up with its own rules, depending on where you are, what you see. And therefore, deciding to open could also be an option, saying, let's open and see how this goes. And then, but you must be sure that if you're reopening, what are your indicators for moving back, for closing again, for limiting mobility? What are those indicators? That's what Kenya needs to think about, that if you're going to open, for example, the curfew or open the borders in and out of Nairobi, Mombasa, what are those indicators we must watch for to decide whether to go back to where we were before or to continue? Those are the things that Kenya needs to think about before thinking about whether to open or to close, or to continue closing.
All right, Dr. Atwoli, what do you think? Should we be thinking of reopening now that we know right now that one person can infect up to 4 people at a go, and then double digits keep coming every other day?
Yeah, I think I would go back to begin by asking the question of why was any closure done? That is the first question. If the closure was done in order that we test within those areas where the infection seemed to be spreading rapidly, then we must demonstrate that we have done that and that we have better information about the shape of that infection in that area. If we're closing those areas so that we can prepare our facilities so that they are able to handle any surge when we reopen, then we must be able to demonstrate that we are now ready to handle any surge when we reopen, and so on and so forth. And it all goes back to one thing. Are we testing sufficiently for us to even use those figures to say that it is now double digits or it is single digits or not? At the moment, we're testing up to about 3,000 per day. We have been informed we have the capacity to test up to 30,000 a day. As long as we're not doing that, then the data we are using might not be sufficient for us to arrive at a conclusion that we know the shape of the pandemic and therefore we should reopen or not reopen. At the moment then, if you look at the countries that you mentioned Uganda. Uganda's argument is that they have very little community transmission and that most of the cases are of truck drivers coming into the country from neighboring countries. They have a solid argument to start trying to reopen and see if that is going to change things. South Africa have an algorithm that they're using where they have level 4, 3, 2, 1, and so on, where they're reopening things, as Dr. Githinji say, in a dial, in that mechanism. Our question would be then, what are we basing the decisions to close or to reopen on? Given that we're not testing large enough numbers, it is difficult for us as scientists to say that the figures we have can justify a decision one way or another. Even if we reopen tomorrow and people mingled and so on, and we're still only able to test 3,000 per day, we might not be able to see the effect of reopening or the effect of remaining closed. So it goes down to the ability to test and looking at numbers that will then inform your next step. What should we do? If we are testing sufficiently and we want to decide on reopening, we must see a trend where the increase in numbers per day is stabilizing and reducing. And the desirable place is where there's no increase in numbers for several days, up to a week or 2 weeks. Then you can say there's no more transmission that we're seeing, and now we are ready to reopen and see if this is going to change. But without numbers, without knowing where it is, it's difficult to make that decision.
And Dr. Atwoli, you've said that we have to decide on the basis of which we are reopening. Is a tattered economy and a shattered economy reason enough to reopen?
So that's a good question, but it's not a good question for a scientist like myself to answer. It's a good question for the politicians who are going to take the political responsibility for the economy to answer. I can tell you the impact of reopening. Then you decide what level of tolerance, how much damage can you tolerate? And then you make a political decision about reopening the economy, but without minimizing the scientific effects that you would be told by the people on the ground. So they will tell you if you reopen, the numbers would increase based on where we are now. We might have a surge in patients. We might not be able to handle them in our hospitals. You will know that. Then you would say, I am making an informed decision to reopen. I can take that damage and I will take the political flack that comes with it.
Okay.
So that is the level at which we are operating.
All right. And Dr. Gidinji, you mentioned earlier on that we should have an elaborate system that even if we reopen, we have a way of walking back our reopening plan. Wouldn't that be more detrimental than where we are now? Because then by the time we decide to walk back our actions, the spread shall be even worse. And maybe some of our hospitals may even be overrun at that point.
No, you see, that's what I'm talking about, indicators. That actually, you see, this whole thing, as Prof has said, let's remember, because we are talking to the general public here, that the closing or the limitation, the restrictions are not about avoiding the spread completely. No, they're not. They're about controlling the rate at which the spread happens so that you do not have a peak in infections that have symptoms that require hospital care, and you can't handle that. So even as I've said before, even on this particular platform, as we talk about a flat curve, remember that a flat curve, the level of flatness depends on the level of your capacity of the health system. So a flat curve for Germany could be a very steep curve for Kenya. So basically what we are saying is this, that the limitations and the restrictions and all these things we are doing are not to finish the infection, to end it. It is to limit the spread and the rate of spread. So when you're thinking about reopening, you're thinking about, are we keeping that curve under the capacity of our health system? Remember some certain facts. For example, in Kenya, in Africa, the number one is that we have seen that 82% of all our positive cases are asymptomatic. They have no symptoms at all. So if you speak of Kenya having 1,000 cases, just for argument's sake, 800 of them have zero symptoms, no cough, no fever, no difficulty in breathing. Then the other 200 have a few symptoms. Some have a cough, some may have difficulty in breathing, and some may have a fever and a few other symptoms. But out of those, these symptoms are mild and some of them are moderate. Only a small percentage are actually severe. As you've seen, the fatality rate, so far I think we have 52 out of the 1,200. So the question is, how much of the symptomatic patients can you effectively handle? Because eventually the infection is going to go to 60% of the population. If we don't find a vaccine in the next 1 year or 2 years, which is very likely, then it means that up to 60% of us will get infected. The question is, out of those 60%, 80% will not have symptoms, will come and go. We must worry about the 3-5% that require hospitalization, that require the hospital capacity. So it means therefore that when you're reopening, you're thinking about, are we seeing a surge or not? And if you see a surge, you must have very clear indicators, which could include, Trevor, not only the tests, but also symptomatic or what we call syndromic surveillance. We must set some parameters in all our hospitals saying we need to be reported, we need reports of how many people report to these hospitals with a cough, for example. We need to know how many people report to either the public or private with fever and cough. We need to know what percentage of people report every day with difficulty in breathing. This is what the government should be working on, this system of reporting symptoms, of surveillance based on symptoms, so that you can then tell, are the cases going up, are they coming down? Without that system, then you are reopening in the dark. So as we Anna, we should be thinking about what indicators we need to put in place to be able to respond quickly within 24, 48 hours, so that we are not waiting for just testing to be a mechanism for opening or closing.
All right, Dr. Atwoli, how realistic is it gunning for herd immunity? Because that's also a conversation that has been had in the medical corridors, that if we reopen the economy, 70% of the people are asymptomatic, we'll all get it at some point, and then we develop herd immunity. How realistic is that perspective?
So I have had a lot of this discussion in lay discussions on social media. In the medical arena, it has not been as rampant as people are putting it. The truth of the matter is that herd immunity is an ideal that we all aspire to for all infectious diseases. And how we aspire to achieve it is by finding something that will protect a large proportion of the people from it, so that those that are vulnerable who haven't got it are protected. And this something is what we call a vaccine. I think it is alien in the medical literature to find a fraternity of doctors or medical personnel saying, let this infection run rampant in the population until we have sufficient people who are immune to protect everyone else. The mechanism we use is through vaccines. There is absolutely no infectious disease in the history of medicine that has been eradicated by allowing people to be infected until a large population is immune. Instead, we discovered immunization and vaccination, which then protects a large population and makes it difficult for that infectious agent to spread. So speaking about herd immunity in the context of COVID-19, you must have sufficient immunological information that confirms that when people get infected, they get immune for a sufficient period of time to interrupt the transmission. That information is still being studied as far as COVID-19 is concerned. You must have sufficient ability to handle the mortality that will come if you allow the infection to run rampant in the population. Even if it is 3% of the population, 3% of a million, 3% of 10 million is a large number of people that you do not want to needlessly sacrifice in pursuit of a mythical concept called herd immunity. So whenever I speak about herd immunity, I speak about it in the context of us finding a vaccine, which, as Dr. Gidinji has said, that's a long-term thing. It might take a year, it might take 2 years. And if we get that, then we can start dreaming about herd immunity. But we cannot speak scientifically about herd immunity, which involves letting people get infected in nature, in the hope that they will develop some immunity that will then protect other people, and in the process risk losing many lives needlessly.
All right. So then
that is how...
Yeah, and Dr. Atwoli, right now as it stands, can our medical system handle a full-blown spread? If we open the economy now and now thousands start getting it, are we able to handle that numbers that will come through to the medical system?
So I will make a disclaimer first and say most of the information is not known, because we do not know a lot of information about how severe the infection will be. We do not know how many people will require what kind of care. But what we do know is that up to 3 to 5% of the people who will get infected, if you open it up, will require intensive care in the hospital. And we know that our intensive care capacity is limited. If we are talking about the largest number of beds that can handle intensive care, we're talking about 500 beds. We also know that our capacity in the hospitals, just for regular beds, is limited. So we don't have enough staff, we don't have enough equipment, we don't have enough physical facilities to handle even our day-to-day care for patients. And so if this surges, like we have 10,000 more patients at a go, we have 100,000 more patients to handle, we will not be able to deal with it. And so we have to be very careful, as Dr. Gidinji says, that if you are opening up, you're ready for any surge that might happen. You have sufficient beds, you have sufficient medical staff, you have sufficient medications and equipment to deal with a large number of patients showing up in hospital at the same time. Even if they just have moderate symptoms, they will interrupt the system of care for the rest of the conditions. Yeah. And this will still have an impact on the health system.
All right. And Dr. Gidinji, there seems to be a bit of a cavalier attitude now with Kenyans as time goes by. We're sort of restoring factory settings, so to speak. But you've been talking about the domino effect of some of this COVID-19 pandemic that has had on several things that people are not even talking about. What are some of those areas that you think are being given as sort of a blackout, but they are very important to the society right now, and they're emanating from the COVID-19 pandemic?
See, I've had several conversations with people, not only in Kenya, but outside, who say, the impact of COVID-19 in Africa seems to be very low. The numbers are low. Let me first say that, and back to what Prof was saying, that number one is, if you talk about infection, let me start here and say, assuming 1% of Kenya was infected right now, if you just took 47 or 50 million to make it easy, and you just say 500,000 people are infected, 80% of them have no symptoms. So you're basically saying that about 100,000 people would have symptoms, and maybe I would say 20,000 of those or so would have severe symptoms. Then you start to see the bad, because people have started to say, why are we not seeing people dropping dead? Why are we not people, seeing a surge in the hospital? The numbers we have are still very low. The moment you start reaching 500,000, a million, then you take 5% of a million, and now you start thinking, first, where are these people? What is the effect on the pharmacies? What's the effect on the clinics? What's the effect on the ICU beds, as mentioned earlier by Professor Atwoli? The moment you reach 2 million, 3 million, so for now, we are in infancy stage of the epidemic. Well, the epidemic has just started. So even the people who are symptomatic could be spread out. So people who had a cough or fever have gone to a pharmacy. No one notices the bump because the numbers are still very low. So let's remember that the fact that we are not seeing these massive numbers in hospital should not cheat us that the pandemic is not with us. It is with us, but once it starts the exponential growth, then we start to see these people, we start to see the surge and the effect on the health system. So we need to remember that we are still very, very low on numbers to start seeing what worries us. So Kenyans are not worried because they're not seeing people in hospitals in big numbers. And they're not seeing people they know who are in hospital. But that, as if we let it go, you're going to see that. Now, but that's only number one. Number two is that as we control the pandemic, we have many other things that happen. First, we have the economic impact. The economic impact is that I personally know many people who've lost their jobs, many people who have had salary cuts, many people who are doing business and they have to close it down. So the impact of that on hunger, for example, on mental illnesses, on just generally livelihood destruction, households, the impact on households is severe. That's one major area to look at. The second thing is to look at other untoward effects of people being out of school. We know that many girls are out of school. We expect that not all the girls who are out of school will go back to school when the schools reopen. Many of them may have undergone female genital mutilation. Many of them will have undergone early child marriage, especially because households that have not enough to eat may decide to actually trade off their girls for livestock, especially in areas where early child marriage happens and FGM happens. So these are other untoward effects. And finally is the impact we have seen on the essential services. We have seen some hospitals say, the Minister of Health, for example, say, please go slow on elective surgery or elective care. Now, we don't know, elective care is that planned surgery, planned care. We don't know how many people needed this and therefore have not gone to the hospital because they had a small lump on their breasts. And by the time they go, it is breast cancer stage 3. It has spread. We don't know how many mothers are pregnant and they can't seek care at night when they're in labor and therefore they decide to deliver in the hospital. We do not know how many girls need adolescent health. They need advice on family planning, but they can't seek it because the clinic nearby is focusing on COVID. So we have to think holistically about the impact of COVID beyond just the infection numbers and the mortality numbers that are being announced. It is actually a more complex issue that we, the government itself and partners and everyone else, needs to think about more proactively. So the reopening can be complicated by some of these issues. And therefore, that's why we're saying it's a dial rather than a switch on off. It's a very complicated issue.
All right, gentlemen, stay with me. I'm taking a quick break here. When we come back, there's still many questions from the viewers. One of them here is Uncle Fredo Bachi Machoka. He's asking this question: is it recommended to vaccinate people who are already infected? We'll pose that question to Dr. Lukoye Atwoli in just a bit, but right after the break. Keep your views coming. Hashtag Monday Reporter Trevor Mbija at Citizen TV Kenya. We'll be sampling some of them to our experts in just a bit. All right, see you in shortly.